Uh, Good afternoon, Mr. Chairman and panelists. I'm Dr. Lợi from Hanoi Heart Hospital. My topic today is Leave Nothing Behind versus Vessel Scaffolding, DCB versus DES in lung lesion. My presentation is supported by Boston Company. And three main ideas in this presentation is the first is a strategy to treat lung lesions. The second is the roles of DCB and DES. And the third is DCB versus DES in lung lesions. As you know, nowadays, the optimal drug eluting technology for many patients remain unclear. And especially with the complexity of the lesion, now some factors influence on the outcome treatments and re-intervention is lesion length, occlusion, and calcification. For we use DCB for Class A, B lesion or instant recent release and no stent zones, and use DES for flow limiting dissection or more than 30 residual stenosis. And the optimal endovascular strategy for lead appears to be highly depend on lesion length. In short FEMPOP IC lesion, DCB or cover stent recommend. For long FEMPOP lesion, we recommend atherectomy with DCB or DES. With short infrapopliteal CLTI lesion, recommend DES or and long infrapopliteal lesion recommend DCB. And nowadays there are 5 DCB and 2 DES on US markets. With the multiple drug eluting technology, with many data comparing effectiveness. In this presentation, we I'm focused on two leading technology in each field. For DCB, this is Ranger versus Impact, and for DES, Olivia for versus Zinver PTX. And in a compared clinical trial, it sees that Ranger demonstrated similar primary patency with half the total dose at 12 and 24 months, with the primary patency around 88%. And Ranger drug-coated balloons has an exceptional outcome with effortless delivery ability, efficient drug transfer. It has some key element that is Ranger is has coated it's coated that is a transfect is lipophilic and hydrophilic, so it can efficient drug transfer, and it has low systemic drug exposure and reduce downstream particles, and it can effortless delivery ability because it has a low stiff anti profile. For with another DCP, it has a lowest step, so we can easily deliver when we use this. And for starting with the DCP, we know that the top tier DCP deliver consistent outcome across lesion length, but vena stenting is common. In short and intermediate lesion, with a lesion less than 130 mm, the primary patency for at 1 year is around with both Ranger and Impact. It's clear excellent, but with the primary patency nearly 90%. But in the long reasons, both Ranger Impact also has the excellent performance. But how many men outstanding being used in this DCP trials? That is a question. And some trial like Impact DCP or compare DCP RCT so that the vena stenting rate increase with lesion length. in short lesion, the odds sampling rate is in 1 in 10 patient. For in the intermediate lesion from we saw the rate stenting rate, also the stenting rate increased every 1 in 5 patient. And for a long lesion, we can see the stenting rate is in every 1 in 2 patient. So that when we face the long lesion, the doctor has when we use DCP, we also face vein outstanding is one half. And this is proved by impact global subgroup analysis. The vein outstanding rate increase with lesion complexity, and along the lesion length is among most factors to put stent. And the reason for provisional stenting were more than 50% residual stenosis in and flow limiting dissection. For the last slide, we saw that for short lesions, the DCP is favored, but with a longer lesion are likely to require a venous stent. And Iluvia is one of those DES stent to favor for long lesion, and have some they Iluvia DS deliver strong outcome regardless of lesion length. It's brought by some trial, and with the short lesion results, it sees that the primary patency at 1 year is so that Elevate DS demonstrated superiority over Zinver PTA at 1 year, and the primary patency is get nearly 50% and 90%. And with a long lesion result, it has also has a good result at the primary patency at 1 year is okay with more than nearly 90%. And the Capricorn trial gave for us a first signal that Olivia DES provides better outcomes and impact DCV in long and complex lesion. And the reason for 1 year primary patency is Olivia's superiority than impact DCP. Although the lesion characteristic, the long lesion with correct total occlusion and calcification is the same. And another trial is a spot. Is compare angiographic and clinical outcomes of TAS-CD lesion in the SFA after treatment with DCP or BMS or with DES. And this trials shows that many long complex lesions initially treated with a DCP written for intervention with stent. And Ilivia DES has freedom from TOR is better than DCP with or without stent, or better than BMS. And this stent is a new standard of care in SFA stenting, because it has a coated hydrophobic polymer. It has lowest rock dose with reduced downstream particulate, and it's sustained release to measure restenosis %. And this is one case. This is a man 60 years old with smoker. The congregation level 4-5, and you see that it is the SFA the calcification packs 5, and we know that it's a severe calcification and stenosis of the SFA. And with this patient, we use atherectomy to remove the plaque of calcification along the SFA. After that, we use a PTA with DCP. We use a NC balloon with a size Mustang 6.0, and then we use a Ranger 6.0. And this final result is better after we use atherectomy and DCP. And summary, uh, leaving nothing behind is a trend of treatment in peripheral artery disease. If it is impossible to leave nothing behind, try to leave as little as possible. DCBs are the predominant SFA drug-eluting treatment choice, and many long, complex lesions initially treated with a DCB return for intervention with stents. So should we start with DES? Thank you for your attention.